All right. Thank you for the opportunity to present our experience on TULSA. Today I'm going to talk about our flexible approach to use TULSA in various prostate conditions, and I will focus especially on the salvage treatment after radiotherapy failure and palliation of advanced prostate cancer. Conflicts of interest. So I will focus today in a few slides about the general use and practical aspects of TULSA. And then I'm going to talk about our trial design and the scientific approach that we have used, and also talk about our practical execution of the TULSA treatment. And then I will focus on two topics: the palliative treatment of a locally advanced disease and salvage in the setting of failure after radiotherapy. So this is general outline how the treatment looks. It's of course MRI guided. We use directional thermal ultrasound to give heat to the prostate tissue and ablate prostate. It's under MRI thermometry in the bore of an MR, and there's a protective element with cooling of the urethra and rectum to avoid damages to these organs. We started with TULSA about 3 years ago, and immediately we decided to have a scientific approach, and we designed a phase 1 trial, which is a registered trial, and we decided to investigate the use of TULSA in various settings in the traditional localized disease. Then of course we wanted to explore other alternatives for the treatment as palliation and salvage, as well as benign prostate hyperplasia, which Dr. Anttinen will talk about. Few words about our approach. Of course, everything starts with the imaging. We do a multiparametric imaging before TULSA. Otherwise, we usually use biparametric MRI. Then we check also the MRI thermometry for any artifacts. And in advanced disease and salvage setting, we rule out metastatic disease with a PSMA PET scan. Then the actual treatment, we have preferred lesion-based, or someone will call it focal therapy, but we have done whole gland ablations as well. We do it under general anesthesia. In most cases, we haven't used suprapubic catheters, but actually in salvage setting, it's the preferred option. And another alternative is to use a Foley for a short period of time. And in the follow-up in our trials, we confirm the ablation with later MRIs up to 1 year. We take biopsies also typically at 12 months. And then the function is measured with patients' reported outcome measures and quality of life questionnaires and urodynamics. So then to the actual trial and studies. We have published 2 papers from this subgroup of focal therapy in localized disease. There has been already ablation and resection trials, but we wanted to do it one more time to make sure that technology works in our hands. And we also added some imaging in between the ablation and the prostatectomy. We accrued a total of 6 men planned to have radical prostatectomy, and the patients underwent focal or lesion-targeted TULSA ablation as shown in the graphs. We could learn that the when we did the MRI 1 and 3 weeks after the ablation, that you could see significant changes in the non-perfused volumes, i.e. the ablation area. And this was confirmed in the histological slides from the radical prostatectomy. And also what we learned, that the ablation area really grows over the time after the ablation. So the immediate MRI underestimates the ablation. Currently, we are running a phase 2 study with a larger cohort of localized disease, which of course are not going to have radical prostatectomy, but TULSA is the actual treatment, and it's running well. Then to the palliation, this is also published quite recently by Dr. Anttinen and our group. It's an interesting cohort of patients with lots of challenges in the treatment. We know that the patients are very difficult to treat. They often have hematuria and obstruction with catheters and retention. And we hypothesize that TULSA could provide an alternative treatment option for these men with difficult symptoms. We know that TURP and other options are available, but they are often challenging as well and have suboptimal treatment results. So we designed a study in the phase 1 safety feasibility setting to investigate if we can treat and ablate the tumor that is causing obstruction and hematuria, our main endpoint was the safety, the catheterization time or need for catheterization after TULSA, and hematuria. And we followed these men up to 1 year after TULSA. Here in this study, we had a total of 10 patients, very difficult patients with very symptomatic, locally advanced diseases, all having permanent catheter use, hospitalizations because of hematuria and other reasons, and all actually had hormonal treatment, and 6 had previous radiation, and 3 had unsuccessful trial of palliation with TURP. Here we can see the cases, how they looked. There's a lot of difference with very bulky tumors like the patient C here, or H, and some patients with slightly smaller tumor burden, but still problems from the tumor. We customized the ablation for each patient. We obviously didn't try to treat the entire tumor, but the part of the tumor that caused symptoms and problems, obstruction and hematuria. The ablation took an average of about 37 minutes, and the average amount of tissue ablated was 31 cc's. We're quite pleased to see that we didn't have any major adverse events, no fistulas or transfusions. There were 3 simple UTIs resolving with traditional antibiotics, and apart from one patient, all were discharged on the day of the treatment or the following day. We also were very happy to see that the treatment was very effective against the hematuria, and we could see it ceasing on all patients. And quite interestingly, when we looked at the need for hospitalization because of the urological issues prior to the TULSA, it was on average of about 7 days in the last 6 months, and 1.4 days following TULSA during the same period of time. This is slightly challenging slide, but here we try to illustrate how the catheterizations and obstruction was resolved. Basically, you can see that in 7 out of 10 men, the obstruction completely resolved with no need of catheters. In one single man, the patient could start clean intermittent catheterizations, and in 2 patients, catheterization was needed even after the TULSA. Here's an example case: 65-year-old gentleman with radio-recurrent disease, T4, castration-resistant. He had continuous catheterization because of obstruction and hematuria, and you can appreciate the mass infiltrating the bladder neck and trigonum. Here you can see the actual ablation. The idea again here was to ablate the tumor obstructing the prostatic urethra. And you can see the thermometry describing the ablation and the actual tissue heating. And in the lower panel, you can appreciate a contrast-enhanced MRI after the treatment with quite significant ablation in the around the prostatic urethra. And here we can see pre-treatment and 1 week MRIs. Cystoscopical image after 3 months, where you can see some necrosis still, but still the prostatic urethra is quite open. And in the last image, you can appreciate the 12-month MRI with very open bladder neck and prostatic urethra. And the patient was very pleased with the symptom relief of both obstruction and hematuria. After these 10 patients and the study which is reported, we can at this point say that palliation with TULSA is very feasible. It's safe with minimal complications within this patient cohort. And what is nice, you can really tailor the approach for the individual tumor, and there's a good chance to relieve the obstruction and especially hematuria in these quite challenging patients. Then the other topic, salvage after radiation. We know that this is also a very difficult patient cohort. We have salvage radical prostatectomy as an option, but many patients are not fit for the surgery or don't accept the risk of complications and decreased quality of life. This is also recently published in European Urology Open Science by Dr. Antinen. As we know, we have very limited options with low good side effects profile to manage these patients, and TULSA has some potential advantages, such as tailored approach and real-time monitoring of the treatment. We hoped that it would be safer than many other approaches with lower risk of fistulas and other major complications. Again, this was designed to investigate especially safety and feasibility, but also efficacy of salvage TULSA. We recruited or planned to recruit 10 men with recurrent prostate cancer after radiotherapy. We did very meticulous restaging with MRI and PSMA PET to make sure that there is indeed disease in the prostate, but not metastatic disease. And then we did either lesion targeted or whole gland TULSA, depending on the size of the lesion. And we followed patients with MRI and PSMA PET, and also with biopsies after 12 months, where we did both ablation zone and systematic biopsies. We assessed a total of 22 men, and 17 so far has been treated, and we have reported 11 patients, as these patients have the entire 12-month follow-up. Median PSA was 6.5, and the median interval between the radiotherapy and TULSA was 11 years. As we know, it's quite a long period of other treatments, and actually 4 of the 11 patients had ADT before the TULSA. Here you can see the actual ablation plans. There were 3 whole glands and 8 with lesion targeted focal approach. The ablation took a little bit longer than in the palliation, on average 49 minutes. And as the prostates are quite small after the radiation and also ADT, in some patients the median ablated volume was only 14 cc's, which is quite significant in this patient cohort. Here you can see a slide of the oncological outcomes. You can see the bars of PSA with significantly decreased PSA levels, with some slight upward trend at 12 months, but still very low levels. And we need to remember that there were patients with ADT before TULSA, but no one continued with the ADT after the TULSA. So we think that this slight increase in PSA at 12 months is likely due to the cessation of the ADT. We also did the biopsies. There was one single case with in-field positive biopsy, very small volume, and this case has been managed with observation after the biopsy. And then there were 2 cases with prostate cancer in the systematic biopsies, and we learned that these were referred patients which didn't receive optimal systematic biopsies, which we currently are doing to all patients to know really the disease extent before starting the TULSA planning. And we also learned that PSMA PET is very accurate in the radio recurrent or salvage setting, both before and after the TULSA. We could identify all cases with PSMA PET. About safety and function, there were no complications immediately after the surgery. Most had some form of a catheter with average 7 days. And we have learned, of course, which is not surprising, that these men take a little bit longer to heal than completely treatment-naive prostates. And even after the catheter, there were a few who had retention and one with UTI, but no fistulas or any other major problems. There could be some decrease in the urinary and sexual function, but these are minimal and in detail reported in our publication. Example case, a hemiablation after failed radiotherapy. 69-year-old man with history of radiotherapy 9 years ago. You can appreciate the lesion both in PSMA PET and MRI on the left graphs, and in the middle you can appreciate the salvage TULSA with the thermometry and the immediate contrast enhanced MRI. And on the right hand you can see the follow-up imaging after 12 years. You can see slight PSMA signal in the prostatic fossa, but that's urine. It's not tumor. Biopsies were negative, and you can see that the initial PSA was 3.3, but it's now 0.34 with very nice results. Another case, here we can demonstrate that you can redo the TULSA even in salvage setting. This is a man with bilateral tumors 11 years after radiation. He had the initial TULSA treatment, but there was some technical issues, a thermometry artifact, and the left apex was not perfectly ablated. And after or during the follow-up, we could appreciate that the right lobe was perfect both in MRI and PSMA PET, but you could see still a residual disease in the left apex. And we did a re-TULSA where we could now ablate the left apex as well. And since this treatment, there's no evidence of residual tumor, and even in the second after the second treatment, his functional effects have been very minimal, and there has been no signs of any complications. So to conclude, salvage TULSA is also technically feasible. And to be honest, personally, I think this is maybe the most important indication for TULSA in our setting and center. Of course, we are interested in managing localized disease, but these challenging radiation failure cases, we really are looking the use of TULSA in the future as well. PSMA PET works very well imaging these tumors, and one needs to expect a little bit more challenges after salvage setting with slower return of urinary function and risk of urinary infections. And we can also see that, or we could demonstrate that even repeat ablation with TULSA is feasible. To conclude, TULSA is a quite flexible technique, as we have demonstrated. You can ablate traditional primary prostate tumor, but you can also use it to other indications as palliation or in locally advanced disease. Yeah, it's also feasible to use it for salvage setting after radiation failure. And of course, we need more studies with larger patient cohorts to really see where this treatment stands next to the other treatments, such as TURP palliation or salvage radical prostatectomy. But there we see a lot of promise and need to investigate this further, and also in salvage setting to really treat the patients as we see this as the first line treatment in our center currently for salvage setting. Generally, we can say that TULSA is quite easy to adopt, but of course one needs a dedicated and experienced team with MR imaging and urologists motivated to pursue the treatment. It's a good treatment option for patients with comorbidities, and usually a very short period of catheterization is appropriate, and it's feasible even to retreat patients with TULSA. Finally, I want to thank our team. We have many dedicated urologists, especially Dr. Anttinen, who is about to publish his PhD on TULSA and prostate cancer. We have very dedicated radiological team as well, medical physics, and also our uropathologists who have helped us with very detailed analysis of the prostate biopsies, both before and after TULSA. Thank you very much.